Good afternoon, everybody. I'll just start off this presentation, and then we'll first of all obviously start you off because a lot of you will not have heard what CPR for feet is. So actually, what is CPR for feet? This actually started off specifically for patients with diabetes, but I've taken the word diabetes out of the title to broaden the scope. But today we are speaking specifically about people with diabetes. So what is CPR for feet? It's a very simple system to make sure on admission to hospital, every patient with diabetes have their feet checked. If their feet are at risk of ulceration, they're protected. And if they have been discovered to have an existing problem, then they have the appropriate referral. So basically, on admission, we make sure they're checked. If they're at risk, they're protected. And if they have an existing problem, then they're referred, hence the CPR. So how was this need for the new inpatient initiative discovered? As Stuart has already alluded to the NADIA data, I was looking at this NADIA data from down south, and then just at that time, as I am employed by NHS Lanarkshire on a clinical basis, I did see this headline that came up in the paper, and this worried me that a patient had been admitted with a problem to one foot, but then developed a problem on the other foot, which resulted in an amputation. And that set my mind thinking, especially it wasn't in my hospital, but it was in my health area, and it got me wondering what could be done about this. Now, we've got to remember that there are a lot of legal issues surrounding episodes of harm that happen to our patients. And we've got to remember that as healthcare professionals, we are increasingly under scrutiny. We are accountable for our patients and our practice, and there is a gradual increase in litigation cases from pressure ulcer development. But we have to be confident that we have assessed our patients and documented our invitations. And this next slide really highlighted this fact to me when I picked up this magazine, which was in the waiting room, which is obviously not a very highbrow medical journal, and looked at one of the inside pages, and it was lawyers advertising their services. Have you or a loved one ever suffered from pressure sores? Now, this is actually what we are up against these days, and this is why we have to make sure we are doing the right thing for our patients. So why do we need CPR for feet? Hospital-acquired ulceration is unnecessary. It delays discharge. It is easily preventable, and it causes unnecessary distress to our patients. It costs the National Health Service vast sums of money, which I will break down for you shortly. And as I've said earlier, it does result in litigation. So the group that I set up in my national role, the Scottish Diabetes Foot Action Group, what did we do? In November 2013, we carried out a snapshot audit of patients in hospital with diabetes of 1,048 patients throughout our health boards in Scotland. So what did that data, when we collated that data, show me? It showed me that 2.4% of the patients with diabetes developed a new foot ulcer while in hospital, avoidable pressure damage. 57% of the patients has not had their feet checked, and 60% of the patients who were discovered to be at risk of developing a foot ulcer did not have any pressure relief in place. Now that data was very worrying to me to begin with, but I thought, well, at least because the data is actually so poor that there is huge room for improvement. So that got me thinking on how we could do something about that. So to break this down into actual monetary factors, that was meaning that in Scotland, 24 patients out of every 1,000 in our hospitals with diabetes acquired a new diabetic foot ulcer or pressure damage to their feet during their stay. The length of stay for somebody with a diabetic foot ulcer is shown to be on average about 13 days longer than somebody without a foot ulcer. There are various costs of bed days in the hospital, but if we take an overnight bed day or a bed day in the hospital being about £650, some people will say it's less. But if that is 24 patients and 312 extra bed days, that's over £202,000. Now, according to the audit, 226 patients did not have any pressure relief. Now, the cost to protect those 226 patients If we said it would be £100 per patient, it would probably be half that, but let's just round it up to £100. That would have cost £22,600. Thus, for every 1,000 people admitted to the hospitals with diabetes, the cost saving for NHS would be £2,002 minus the £22,000, so it would be a cost saving of £180,000 for every 1,000 admitted to hospital. Now, if we look Scotland-wide in that, if we only prevent 75% of these avoidable ulcers, it will be a saving of £135,000 per 1,000 patients. In 2013, we had over 500,000 inpatients discharged with diabetes. 500,000 patients were discharged. We know around 20% have diabetes. So if we calculate that up, there is a potential saving to NHS Scotland of £15 million a year by just doing the right thing. So remember, that does not include the cost of any litigation if a patient ends up with an amputation, and also, very importantly, the human cost of being in hospital unnecessarily or losing a limb. That is why I feel we need CPR for feet. So exactly what is it we're trying to avoid? This is especially for the non-specialists, non-diabetes specialists. Grade 1 pressure damage up to grade 4 pressure damage. The heel is the second most likely place to have pressure damage after the sacrum. That is why we need to prevent this preventable problem. So the cost of pressure ulcers to the patient, I've spoken about the monetary fact. We're looking at a reduced quality of life. I've alluded to the increased length of stay in hospital. There is a risk of amputation, and ultimately there is an increased risk of morbidity. All the latest guidelines, whether they're NICE guidelines or the new Health Improvement Scotland prevention and management of pressure ulcers, there's the SKINS programme down in England, there's the 1,000 Lives campaign in Wales, and in Northern Ireland they have their own safety programme. But the key messages from all these recent guidelines, the cost of prevention is much less than the cost of treatment. Decreasing the incidence of pressure damage and pressure ulcers will release staff, resources and hospital beds. We need to reduce the additional costs of treating these ulcers. And as I've alluded to before, a patient with diabetes can remain in hospital 13 days longer if they develop problems. And this has an ongoing effect to reduce the community services post-discharge for these patients. So who's actually at risk? Elderly, frail, immobile, bedbound, malnourished, or of what I call the special risks, patients with diabetes, vascular disease, CVA, renal impairment during surgery and post-op patients. So let's introduce the safe and standardised care. We know all medical, podiatry, orthotic staff are very busy, so we need to introduce practical guidelines to keep patients safe, but they have to be simple. They cannot be too time-consuming, and they have to be standardised to ensure consistency. And most importantly, if we're going to get implementation, they must be cost-effective. I do hope CPR will move on. It was initially designed purely as an inpatient campaign, but we know it is much wider ranging, and not just for hospital with community settings, not just for people with diabetes, but that is something for another day. So what resources are available to you and your health boards to help you introduce CPR for feet in your hospital wards? There, as Debbie has alluded to, there is a Learn Pro module, CPR for diabetic feet. I do have a training manual I have developed which will allow your implementers to follow to train people at ward level. There are laminated posters which will be available to you for each of your wards. There's also a simple pressure relieving algorithm to direct clinicians towards the correct pressure strategy, remembering that not one size fits all, and we need to direct clinicians towards the appropriate pressure relief that will be tolerated by the patient. This is an example of a pressure relief algorithm that can be adjusted depending on the strategy per health board, and I will liaise personally with them and organise those for them. We have newly produced CPR cards, which are badge holders, double card holders. The name badge can be on one side and the CPR card can be on the other, which is a constant reminder. And it has a mirror on the back so that people who are checking patients' feet don't break their back while checking heels, but can use the mirror, which you will see, which is at the back of the card, which I've taken a picture of to show you. Those will be available not for every member of staff, but for the main members of staff who will be assigned to this programme on each ward. In NHS Lanarkshire, we're looking at changing our paperwork, yet again, not making it complicated, just a very simple area that mentions CPR, have the feet been checked, if they need to be, have they been protected, and have they been referred appropriately if required. Implementation, there's various ways of doing this, awareness days, ward-based training, as I say, the ward-based posters, having the appropriate pressure relief on automatic top-up in the wards, basically something that's been approved and held within the NDC. Assigning pressure champions in each ward I think is absolutely crucial, and aligning that with the care assurance and accreditation CAS standards can be very successful. So let's check, protect, refer. You now have access to these tools from this national initiative. I can help support your health board via my role as Diabetes Foot Coordinator. But don't think you'll just be able to snap your fingers and this will be introduced and effective. We all have to know the new initiative needs effort and time driven by committed people. So in conclusion, hospital-acquired ulceration is preventable. It is costing large sums of money from your valuable budget. It is a patient safety issue. It is increasingly resulted in litigation. It does result in unscheduled bed days. So we need to prevent what is preventable and basically do what we should have been doing all along. Thank you for listening.
I'm going to hand over to Stuart now, and he's going to speak to you about some work that they did in insulin safety.
So I'm going to hand over to Duncan Stang, who's going to update us all on CPR for feet.